All right, I am back. Let us resume. Can everybody hear me? Indicate. All right, so let us continue. Principles of safe reaching and pulling, body drag. The same body mechanics and principles apply to moving, lifting, and carrying a patient. You keep your back locked by tightening your abdominal muscles, kneel, extend your arms no more than 15 to 20 inches in front of you. Alternate between pulling the patient by flexing your arms and repositioning yourself. All right. To drag a patient across a bed, kneel on the bed to avoid reaching beyond the recommended distance. So you get as close as possible to the patient. You drag the patient to within 15 to 20 inches. Complete the drag while standing at the side of the bed. So you kneel on the bed, then you drag the patient to the edge of the bed. Then while standing, you bring the patient over to the stretcher. All of this is going to be practical. Use a sheet or blanket under the patient rather than dragging the patient by his or her clothing. And that is my ideal method for moving patients, either a blanket or a sheet, right? In the hospital, transfer the patient from the stretcher to a bed with a body drag. The stretcher should be the same height or slightly higher than the bed. You and your partner should kneel on the bed, drag the patient gradually over to the bed. Mentioned this earlier, to properly perform a log roll to a spine board, you need at least 4 persons. Somebody to control the head, somebody to control the upper body, mid portion, lower extremities, right? The person at the head will give the command. We will move on, turn the patient on the side. Once the back is available, you always check the back. So prior to putting the patient on the spine board, ensure that you check the back and lower extremities for any injuries. Then you put the patient on the board. Once the patient is on the board, you do not push the patient across the board. If the patient is not properly positioned on the board, you move the patient down and up until the patient is properly centered. All right, now, whenever possible, use a device that can be rolled. Now, wheel device is not available. Make sure that you understand and follow the guidelines for carrying a patient on a stretcher. All right, now patient weight. Estimate the patient's weight before lifting. Adults often weigh 120 to 220 pounds. They can weigh less than that. Than 120, they can weigh more than 220. Right? Make sure you recognize when their weight exceeds what you can manage. 2 EMTs should be able to safely lift this weight. I stated this earlier. So you and your partner should be able to handle 225 pounds on your stretcher. You cannot do that. You don't meet the requirements for this course. Try to use 4 providers to lift when possible, right? So in certain situations, you might need additional persons to help you lift if more strength is necessary. Do not attempt to lift a patient who weighs more than 250 pounds with fewer than 4 providers. Know the weight limitations of the equipment and how to handle patients who exceed weight limitations. Lifting and carrying a patient on a backboard or stretcher, more of the patient's weight rests on the head half of the device than on the foot half. Explained this already. The diamond carry and the one-handed carry use one EMT at the head and foot and two at the side, and there's a picture of that. So this is what we call a diamond carry. Use 4 providers, 1 provider at each corner of the stretcher to provide an even lift. When rolling the wheeled ambulance stretcher, make sure that it is fully elevated. Your partner should control the head end and assist you by pushing with his or her arms held with the elbow bent. Now this is your steer chair. So this is a steer chair. The ambulance should have a steer chair. The purpose of the steer chair is to move a patient from upstairs to downstairs. That I would say can be in a seated position, right? You're gonna need 3 rescuers, right? So 1 person to control the upper portion, which would be up here, 1 person to control the lower portion, which would be here. They need a 3rd person to count the steps or be a guide, right? So use a steer chair to carry a conscious patient up or down a flight of stairs. This lightweight wheeled folding chair has a molded seat, adjustable safety straps, and fold-out handles at both head and feet. Now moving a patient on stairs with a stretcher, a backboard should be used instead for a patient who is unresponsive, right? Patient unresponsive, then you may have to go with a backboard or even a basket stretcher. Who must be moved in a supine position, then you may have to go with a backboard. Who must be fully immobilized, then you may have to go with a backboard as I suggested, or a basket stretcher. Moving a patient on stairs with a stretcher, carry the patient on the backboard down to the prepared stretcher. Place the strongest EMT at the head and foot end with the taller person at the foot end. Place both the backboard and the patient on the stretcher. Secure both to the stretcher with additional straps. Loading a wheel stretcher into an ambulance, ensure the frame is held firmly between hands so it does not tip. Newer models are self-loading. I explained this earlier. You just tilt it over and let the wheels lock in place, and then you press a button and it will load itself into the unit. Other models need to be lowered and lifted to the height of the floor of the ambulance. That was the old type model. Clamps in the ambulance hold the stretcher in place, so it needs to be locked in place once you load it into the back of the ambulance. You must have it locked in place. That's just going to move all over the place when you're driving. All right, now directions and commands. Team actions must be coordinated, right? Team leader indicates where each team member should be, rapidly describes the sequence of steps before lifting. That's the role of the team member. So you determine who goes where and what their role would be, right? And explain clearly what is it that you want to do and how we are going to get it done. Pay attention to what's happening. Right, now preparatory commands are used. Example, team leader says already stop. Get team's attention. Team leader says stop in a louder voice. Countdowns are also used. Carefully plan ahead, right? Select the methods that will involve the least amount of lifting and carrying, right? And if you can put something on your wheel stretcher to move it, put it on the stretcher to move it. So don't carry what you can put on wheels. Consider whether there is an option that will cause less strain. All right, now let's talk about emergency moves. Now, an emergency move is when you come on a scene, right? You're on a scene and there is a danger. So there is danger to the patient, there is danger to you and your crew members. You have not assessed the patient yet, right? You just recognize that there is danger. So you are going to quickly move this patient before initiating any type of assessment or care. That's what we call an emergency move, right? So let me repeat that. An emergency move is when you arrive on location. You have not made an assessment of your patient, but you recognize that there is something present on that scene that may be a danger to you, your crew, and the patient. You're going to quickly use what is referred to as an emergency move and move that patient from the area. Then initiate assessment. So that's an emergency move. And all of the drugs are emergency moves. Arm drugs, underarm drugs, clothes drug, blanket drugs, these are emergency move. Firefighter drugs, emergency move, right? So use when there is potential for danger, fire, explosives, hazardous materials. Use when you cannot properly assess the patient or provide immediate care because of the patient's location or position, right? Now, if you are alone, use a drug to pull the patient along the long axis of the body. So keep the body straight, as straight as possible when you're trying to move them. Use techniques to help prevent aggravation of the patient's spinal injury. Clothes drag, blanket drag, arm drag, arm to arm drag. These are all emergency moves. Clothes drag, blanket drag, arm drag, underarm drag, right? And if you can't manage the patient, don't try and move the patient. All right, now to remove an unconscious patient from a vehicle alone, move the patient's leg clear of the pedals, rotate the patient so that the back is towards the open car door, place your arms through the armpits and support the head against your body, drag the patient from the seat to a safe location. That's an underarm drag. All right, no, so that's emergency moves, right? You find the patient, there's something present on the scene that is a danger to you, the patient, your crew, you may have to use an emergency move. It could also be you find the patient in a position, and the position that the patient is in, you are not able to properly assess the patient, so you need to move them. But mainly it's going to be because of danger. No, urgent moves, right? Urgent move. An urgent move is needed when you arrive on the scene. This is where you have started to initiate your assessment of your patient, right? And you realize that something is critically wrong with the patient, airway, breathing, circulation, or level of consciousness. The ABCs are compromised. But the position that the patient is in you cannot address these issues based on that position. So the patient's level of consciousness, airway, breathing, and circulation, right, is compromised, or it's an extreme weather condition. But the position in which the patient is in, you cannot properly address the issues. This is where an urgent move becomes necessary, right? And an example of that would be rapid extrication, right? Unlike the emergency move is done before assessment. The urgent move is done after assessment. And an example is rapid extrication. So this is a patient that is involved in a motor vehicle accident. When you come and assess the patient isn't responding. Rapid extrication, that's an urgent move. Now, rapid extrication technique should be used only if urgency exists. The patient can be moved within 1 minute, and any team that is going to perform rapid extrication, it must be something that the team practice or does regularly, right? It needs to be quick, it needs to be fast, it needs to be technical. You need to have control of the situation, the patient. This technique increases the risk of damage if the patient has a spinal injury. Now, if the patient was responsive, you would have put on a C-collar, put a sharp backboard or a kid, and take the patient out. In rapid extrication, all we're using is a C-collar and a spine board. So you put on the C-collar, turn the patient quickly, get the patient on the spine board, get them out of the vehicle into the stretcher on the stretcher into your ambulance. It's quick. All right, now non-urgent moves are done when your patient is stable. If your patient is stable and there's no need to rush, you'll use a non-urgent move, and this will be the move that is most suitable for you and your crew members, right? So use when both the scene and the patient are stable. Carefully plan how to move the patient. Team leader should plan the move, right, based on personnel, obstacles identified, type of equipment available, and procedure and path. Choose between. I have various types of non-urgent move. Just use whatever you think is suitable for the situation. Have your direct ground lift. Patients with no suspected spinal injury or supine, patients who need to be carried over some distance. EMT stand side by side and lift and carry the patient, right? We have extremity lift for those patients with no suspected spinal injury who are supine or sitting. Helpful when the patient is in a small space. One EMT is at the patient's head, the other is at the patient's feet, and you coordinate the move. So somebody's controlling the extremity, somebody's controlling the lower extremity, and somebody's controlling the upper body. They lift the patient. Transfer moves, you have direct carry, where you lift the patient directly and move them. You have the draw sheet method, which is my preferred method. You have the scoop stretcher, and you might draw for your scoop stretcher if the patient is kind of heavy, right, or obese. That might be a good option. All right, now with the geriatrics. Now, most patients transported by EMS are geriatric patients. Skeletal changes may cause brittle bones, right? Skeletal changes may cause brittle bones, rigidity, and spinal curvature that presents special challenges. Allay the patient's fears with a sympathetic and compassionate approach, right? So you have to take into considerations that your bones are brittle, them skin break down easily, right? So putting them on a rigid surface might not be that comfortable, right? and if a spine board is all you have, you may have to put some blankets over that spine board. Or if you're in a service that have the relevant resources, then you may draw for a vacuum type stretcher, which that conforms to the shape of the patient. So that's ideal for geriatric patients. Right? If they have abnormal curvature of the spine, you may have to pad wherever there is space between the patient and the device. Once you're on your moving device, you're gonna have to pad anywhere there is space. Right? So these areas would have space when they're on the device. You may have to pad that. Right? Right, now for your bariatrics, refers to management of obesity. 76 million US adults are obese. 30 to 40% of adults are obese. Approximately 17% of the children are obese. Back injuries accounts for the largest number of missed days of work, right? So, take proper body mechanics and recognize our limitations, then can get back injuries. So stretchers and equipment are being produced with higher capacity. Does not address danger to users of that equipment. Mechanical ambulance lifts are uncommon in the United States. So they have specialized stretchers. This is a bariatric stretcher. They have bariatric ambulance units, right? So bariatric stretchers specialize for overweight or obese patients, wider wheelbase for increased stability. Right? Some have a tow package with a winch rated to hold 850 to 900 pounds, regular stretcher rated to for 650 pounds maximum. You have the pneumatic and electronic powered wheel stretchers. These are for the rich services, right? Everything is button press on this stretcher, movement, all of that, right? So battery operated with electronic controls to raise, lower the undercarriage. Increases the weight of the stretcher hazardous in uneven terrain. So because it's so high tech, it's heavy. Then you have your portable folding stretcher, which is very common out here. You see them a lot in the football matches. I'm sure the JDF might have some of these as well. Right? So strong rectangular tubular metal frame with fabric stretched across it. Right. Some models have two wheels. Some can be folded in half using difficult to reach areas, way less than the wheel stretchers, right? So adverse terrain, that's where you might consider using this type of stretcher. Then you have the flexible stretcher, excellent for storage and carrying, conforms around the patient's sides, useful for confined space, uncomfortable but provides support and immobilization. This is your KED. So this is a short backboard device, KED, Kendrick extrication device. So the Kendrick extrication device is used to remove a patient from a motor vehicle accident that is stable but has a significant injury or an injury that is preventing them from moving. So usually it's going to be a patient that's conscious, but the patient is injured so they can't move on their own. If the patient is semi-responsive or unconscious, then you would do rapid extrication. You would not use a short backboard. You would only use a C-collar and long board or spine board. So that's the Hendrick extrication device. At least, let me see, one, two, at least 4 persons are required to use this device effectively. Then you have the vacuum mattress, alternative to backboards for immobilizing geriatric and pediatric patients. Air is removed from the device, allowing it to mold around the patient, provides immobilization, comfort, and thermal insulation. All of that is important to pediatric and geriatric patients. Then you have the great basket stretcher, right? So the basket stretcher is rigid stretcher, also referred to as the Stokes litter, right? This is for when the patient is in some adverse terrain area, hillside, at the foot of a hill, I should say, or cliff. This is a stretcher that we're going to use to move. Well, it's not me, I'm going to use it because usually it is a specialized rescue team from the fire brigade that is going to come with that particular stretcher. Used for patient removal in remote locations, including in water rescues and technical rope rescues. Right? So I ain't training all of that. So, but I've seen the stretcher used because I had a patient that fell off the side of a cliff. I think it was about 15 feet and landed on a rock, right? On his back. And I had to contact the fire brigade for a rescue team. That did not mean in Jamaica, I'm talking about overseas. And they sent a rescue team. This was the stretcher that they used with ropes to get the patient up to where I was. Basket stretchers. If the patient has a spinal injury, secure the patient to the backboard and place it inside the basket stretcher to carry the patient out of the location. When you return to the ambulance, lift the backboard out of the basket stretcher and place it on the wheel stretcher. So this is what is referred to as a scoop stretcher or orthopedic stretcher. So this particular stretcher is for your obese patients or patients that you might not be able to log roll because they have injuries on both sides of the body. So you can't log roll them, right? It's a stretcher that you can pull apart. So right here, so can pull apart, right here, so can pull apart, and then you separate it and put half on the right side of the patient, half on the left side, and then you lock it and scoop the patient. That's what a scoop stretcher does. Now you have scoop backboards. You have backboards that can do the same thing. You can pull it apart and scoop the patient onto it. So scoop stretcher splits into 2 or 4 pieces. Pieces fit around the patient who is lying on a flat surface and then reconnect. Both sides of the patient must be accessible. The patient must be stabilized and secured on the scoop stretcher. Now, because it has to be locked under the patient, the risk of pinching the skin exists, the risk of pinching tissue. I've also had situations where a part of the fractured bone got caught when it was being locked under the patient, right? So you have to look out for that. All right, now neonatal isolate, sometimes called an incubator. Neonates cannot be transported on a wheel stretcher. The isolate keeps the neonate warm and protects the child from noise, draft, infection, and excess handling. The isolate may be secured to a wheeled ambulance stretcher or freestanding. All right, now decontamination. Decontaminate equipment after use for your safety, for the safety of the crew, for the safety of the patient, and to prevent the spread of diseases. Patient positioning. Proper positioning depends on the chief complaint. Patients with head injury, shock, spinal injury, pregnancy, and obese patients need special lifting and moving techniques. A patient reporting chest pain or respiratory distress should be placed in a position of comfort, and that's usually going to be upright in a high fowlers or semi-fowlers. Patients in shock should be placed supine. Patients in the late stages of pregnancy should be positioned and transported on their left side. Why? Because when they get close to full term, as the size of the uterus increase, that can create pressure on the venous system. So if they lie completely flat, the pressure can be increased on the venous vessels, and that can reduce the amount of blood returning to the right side of the heart. They can develop what is called supine hypotensive syndrome. When they're close to full term, we do not transport them flat, we transport them on the left side to ease pressure of the vena cava. An unresponsive patient with no suspected spinal injury should be placed in recovery position if they have good or visible chest rise. If the chest rise is not good, then they have to remain supine because you have something that you need to fix. And you can't fix ventilation with a patient in recovery position. A patient who is nauseated or vomiting should be transported in a position of comfort. And make sure you pay attention to the patient's airway. Obese patients should be positioned the same as other patients with similar condition. However, keep in mind that you may have to elevate the upper portion of the stretcher if the patient is obese, especially if you're trying to bag that patient, right? Because when they are flat, the weight is coming down on the chest, and if their upper body is too low in comparison to the lower body, it will cause shifting of the structures, which can create pressure on the diaphragm and make it difficult for the patient to breathe, right? So medical restraints. Evaluate for correctable causes of combativeness, right? So when you're thinking about restraining a patient, you need to also consider if there is something that is affecting perfusion of the brain while the patient is combative. Is there a head injury? Is there low oxygen levels in the blood? Is there low sugar levels in the blood? Follow your local protocols, right? Generally speaking, restraints, if you're going to physically restrain a patient, at least 5 personnel are needed. You might need more than that, right? I've had a patient with a brain bleed. Yes, he was bleeding on the brain. That required 7 to 8 of us to physically restrain him because he was combative. And all I had control of was his leg, right? All I had control of was this guy's leg. And when I went home after that call, I was physically drained, right? I was exhausted after that call, right? And all I had was his leg. The guy was a former football player, right? Had a brain bleed, a blood vessel burst in his head, started to become combative. And that guy was ridiculously strong, right? Ridiculously strong. And I'm using proper restraining technique, and I was exhausted. Now, one of the things that you need to keep in mind is that when you're restraining, you have to have control of the joints, right? You must have proper joint control. So you cannot allow the joint to to flex the extremity, right? You want to put pressure on the joint so that the extremity remains extended. That's how you're gonna get proper control. So when the joint is extended, it becomes weak, right? If the joint is flexed, that becomes strong. So if you don't have control over that joint, all the patient is going to do is pull you back and forth. So you have to ensure that you control wrist and elbow joint so that the patient can bend the limb to pull you back and forth, right? The strongest person need to control the head and the upper body. And usually, if you have good control of the head, anywhere the head goes, the body will follow, right? So if you have good head control and control the hips, right? So you push the patient's hips out, like that, you have that type of control from the back. Anywhere the head go, the body will follow. You cannot hesitate, right? So if you're going to hesitate where restraining the patient is necessary, don't be a part of the team. You cannot hesitate. We need forelimbs controlled. We need the head control until the patient can get a sedative. Now, it is not a task in the States for EMTs to restrain. So apart from working at the hospital when I was doing my internship, I don't physically restrain patients, right? What I will do is provide chemical restraints. The police will restrain you, well, I can't say you, but the paramedics give the medication to calm the patient down. Out here, you might not have that luxury. The police, they might stand off and expect you to go restrain the patient, especially if you're working in a hospital setting, right? But remember what I said, if it's something you are not comfortable doing, then you should not do it, right? So if follow your local protocols, that is what is going to guide you. No less than 5 persons. Strongest person control the upper portion of the body. You need control of all 4 limbs, right? Do not put the patient in a prone position. So don't restrain the patient in a prone position or restrain the patient in a manner where it can result in physical harm to the patient, right? Apply a restraint to each extremity. Assess ABCs, mental status, and distal circulation after restraints are applied, and document all information. All right, now personal consideration. Questions to ask before moving a patient. Am I physically strong enough to lift and move this patient? And it's funny, but the healthcare providers, paramedics and EMTs that I've worked with in the States are overweight. They are overweight, right? But the good thing in the States is that you have a lot of hands on deck. So when there's a call, you have police officers might be available, you have firefighters. The firefighters are usually in good shape, right? And they will help with the lifting. So in the States, when I needed to move a patient from upstairs to downstairs, the firefighters put the patient on the stair chair and assist the patient down, right? So over there you have that the manpower available to assist you move patients, and it can still be challenging. Out here, it's like each service is independent. So in Jamaica, a private service is independent, meaning if they are called to a motor vehicle accident, they are not going to contact the fire brigade to assist them, right? And I think we need that type of relationship needs to be established. So if the fire respond to a motor vehicle accident and they don't have enough personnel, or know that they're going to need more personnel, contact the nearest private service, right? Contact the police. The police have an ambulance for their officers. So I don't understand why it's independent operation. So if I am working for a private company and it's just me and my partner, if we go on a motor vehicle accident and need help by ourselves, if we go to a home for a patient with a medical condition, they need assistance. You can't get it from an outside source, right? And you may be on a call within a private service, and another unit for that private service or other units are not available to assist you. So I don't know. It doesn't make sense to me, because there are certain emergencies where 2 responders will not be sufficient, right? If it's spinal injury, 2 responders not sufficient. You're gonna need additional resources. If it is a cardiac arrest in the field, 2 responders is not going to be efficient. But it is what it is. It is what it is where Jamaica is concerned. Is there adequate room to get the proper stance to lift the patient? You need to think about that. Do you need to move anything? Do you need to reposition yourself? Do you feel awkward, right? Do you have proper balance? Do I need additional personnel for lifting assistance? Very important, right? Injured EMTs cannot help anyone. So an injured EMT is a nuisance, right? A dead one, you can't do a thing anybody, right? Keep that in mind. Your personal safety comes first. That's lifting and moving in a nutshell. It's a practical chapter. A lot of it won't make sense until you're physically doing it, right? So it's a practical chapter. Any questions? So I am assuming, well, for the JDF, it is my expectation that you guys can easily manage the weight of a stretcher. That is my expectation. That is what I have seen in the past. That is what I expect to see now and in the future. So I'm not going to ask you this question. Manning, your private candidate, right? I'm talking specifically to the private candidate, not to the
Yes, sir.
JDF. What are you, do you think you can physically, with the assistance of somebody, manage 225 pounds on the stretcher?
Yes, sir.
Oh, you know that. What
Well,
kind of,
I exercise, lift weights, not bulky, but I do exercise regularly, at least four
oh,
times a week.
okay. What does your exercise routine entail?
A little bit of running, burpees, push-ups, pull-ups, sit-ups.
Okay. All right. What about the rest? Private candidates. Rochelle, you present?
Present, sir.
Right. Manage the physical demands of this course?
Yeah, definitely.
Connection sound bad. You're not close to your mic.
You hearing me better?
Yes.
I'm saying I definitely need to do some more exercises, like running. But I think I can.
Remember what I said, So remember what I said, guys. If you are not able to demonstrate that to me, you will not be allowed to complete the course. So if physically you are struggling with the weight, I'm not gonna allow you to complete the course. Now the other question I'm gonna ask, and I'm asking that question while I'm still recording. Does anyone currently in the program have any back or knee injuries that is going to prevent them from lifting?
No, sir.
All right. All right. It's on record. No. All right. We will find out eventually, right? So you have to be in good shape. That's a must. Why did I say a much? A must, right? You don't have to be extreme as I am. So I don't expect you to go find a martial arts school and join up with that school. I didn't do martial arts because I EMS. I went into martial arts because I was a correctional officer, right? So, but I love martial arts, so that works for me. That keeps me in shape. Might not be in great shape right now because of COVID, but I can still manage, right? So find something that works for you. Strengthen the muscles in your back, strengthen the muscles in your legs, have a proper balance in your workout, right? You need an aerobic routine, you need some strength training, and you need flexibility. Flexibility is important. So work on it, make sure you're eating properly and you get adequate rest. If you're not getting adequate rest, make sure you have some form of vitamin supplement in your diet. Yes, Mr. Cameron.
So, boss, but we know look at the fighting business that you know.
Which fighting? I don't know. No fighting.
Yeah, man, we do boxing and them thing that can counter.
Come on, I know that you guys do boxing. So you that do taekwondo as well.
Rufus. Yeah, so we have look at the physical business that we are talking about, you know.
Oh, Mr. Rufus.
Yes.
Ashanti no balloon not even not the deal close matter. Far mistake from a deal man, yeah.
Oh boy. Yep, but I know there is boxing down there because Frank do boxing. I don't know if he's still doing it. I can't see.
Frank never ready, my boss.
And German need to fight contender.
Don't not disrespect me, my brethren, you know. All right. It is what it is. It's a part of fighting. You can't win all of the fights, right? That's something that is a part of doing any contact sport. But as I say, you don't have to be that extreme. Just make sure that you're doing enough to increase your strength, your flexibility, and the capacity of your lungs and your heart. And you should be fine. And it's technique, it's not strength, right? And you'll learn that when I see you face to face. Now, there are some things that you need to keep in mind once you can physically. So once you can physically stay on one side of a patient, once you can physically, I come in Miss Rush, CFAS. Once you can stay on one side of a patient and touch the opposite side of the patient, you can turn that patient, right? And you can use the weight of that patient to turn them. And I'll teach you how to do that when we start to do the skills. Yes, Rochelle.
So when
Physical, we're not gonna have any physical. We're gonna have face-to-face sessions, and that's gonna be in December. Those are scheduled to begin in December. You have to double check the timetable for the date, right? Now let me turn off the recording now.